Good evening, everyone, and welcome to this session on day case TAVI. My name's Sam Dawkins. I'm an interventional cardiologist from the UK. First, I'd like to say how happy I am to see a completely packed room. I thought everyone would have gone for dinner by now, so delighted to see you here. And it perhaps reflects the importance of what we're going to talk about now. You will have seen not so long ago that we have new ESC guidelines which recommend TAVI for anyone over the age of 70 with tricuspid anatomy and suitable vascular anatomy. That is a major change. In the UK, the median age of TAVI is 81. So we've got a long way to go, and we're going to have to increase volumes a great deal, and we need to do that creatively. We don't have a lot of new hospitals, so we need to work out how to make the very best use of the resources that we have. In this session, we have a very experienced and multidisciplinary panel. So we have Iqbal Malik, Seth Vijay, Francesco Sayer, Sandra Lauk, and Gemma McColmott. I am delighted to be joined by Claire Appleby, who is the spokesperson for this session. Claire, we want this to be interactive, is that right?
Yeah, absolutely. So you'll see on the agenda, there's plenty of time for discussion. So really encourage you. There's the microphones, or use your app, and we'll get the questions and aim to give you our best answers.
So these are the learning objectives for this session. It's not that often that the UK is leading the way in something, but we're certainly leading the way in day case TAVI, and we've got some of the pioneers in the field here today. We have split this into three parts. We're going to talk about the mechanics of day case TAVI, we're going to talk about the team, and then we're going to think about how this could perhaps be expanded to different geographies. But the fun bit is the discussion, so as you're hearing the talks, please do think of your questions and be ready to share them, because we'd love to hear your thoughts. So let's make a start. Let's get on with the first session.
Great. So I'm Iqbal Malik. I'm a cardiologist in London at the Hammersmith Hospital, and I want to convince you that day case TAVI is actually a reality in 2025. So we know that aortic stenosis is a really deadly disease. In my hospital, people are bored of hearing me say it's cancer, but probably worse than cancer, and so a 2-week wait to see me is fine, and I want the CT scan on the day I see them. So that usually happens because I'm that sort of guy, but actually it's not universally understood that it is as bad as that. You can see that the UK, not only is it not in the EU, it's probably not in the first world, and you can see that our numbers are lower. They're better than they were in 2019, but not that much better. So this is data from a paper from 2021, which looked at the couple of years before. The average wait for a TAVI was 4 months, but it could be over 8 months, and there is a huge discrepancy across the geography of the UK. The Hammersmith is probably at the lower end of the spectrum, probably about 1 month to get all the tests done and get the MDT, another 6 weeks to get your TAVI, so probably better than average. Why is that the case? Well, it could be that we don't have any cath lab time. It could be that we can't get a cardiac CT. It could be that the commissioners don't want us to do TAVI, but actually often it's beds. Our beds are in very short supply. The NHS runs at probably over 100% bed occupancy, and so we often don't have the bed and have to cancel. So hence day case TAVI, because then we don't need to use the hospital's inpatient base. So a couple of papers from 2024 saying, look, this should be possible, it's fairly safe, but I'll highlight that in 2017, the Hammersmith group asked the question, is day case TAVI a reality? And during COVID is when we did our first day case TAVI. The poor chap was on the surgical waiting list at 71. The next week, the hospital closed down for all surgery, and he got handed to me, and I told him, we have no ITU beds, you're going to get a day case TAVI. If you misbehave, there's nothing we can do, you're dead or alive. He went home. So the meta-analysis of the data suggests that in about 3,500 patients in thick studies, about 9% had a same-day discharge. That's not quite the same as a day case TAVI because they may have come in the night before. A lot of them were balloon expanded. We're all more comfortable with balloon expanded valves and self-expanding. And compared to the inpatient group, there was no difference in death, no difference in readmissions, no difference in anything in particular. So what about our imperial data? We're now at TAVI 280 as a day case. It's about a third of all our TAVIs each year. The restrictions are now very limited. They have to have a home environment where someone is there with them. It's a transfemoral approach, and we're not going to be so worried about the ECG that we're going to have to hold of them. That's it. That's all the restrictions. So here are the numbers. You can see that's my day of the week. One day case TAVI. We usually get inpatient beds. 2 on that day, 1 on that day, and occasional elsewhere. The majority are balloon expanded valves. And for the balloon expanded valves, the Edwards valves, you can see that a lot of them had no pacemaker in advance. Some of them did. If we're using self-expanded valves, then we tend to put those in where we're already comfortable with the pacing, although now we've become more comfortable with both with Abbott and Medtronic valves, and so we're trying to choose, perhaps with FEOPs, the ones we could do self-expanding valve and still do it as a day case. So you can see the numbers, the majority balloon expanded valves, and then a smattering of the others, often with a pacemaker. So the total is 280. How good were we at doing day case TAVI? Well, 170, so over 60% went home the same day. Is that a fail for the program? I don't think so, because that's 170 that did not take up a hospital bed. Another 30-odd% went home the next day. We kept them because we were uncomfortable about the groin or the ECG or something else. So the total that got home within 24 hours of their TAVI was 93%. And we've got a prospective program. We want to work out how we can make it better. And as our confidence grows, so we've managed to send more and more people home. It's the reluctance of the team and the cardiologists, the confidence sending them home. That's also important in deciding if you go home. So here's an example from a couple of weeks ago. This is not a particularly well-chosen one. This is what I do on a Monday. She's 85. CKD, ischemic heart disease, osteoarthritis, Parkinson's, severe aortic stenosis, seen by one of my colleagues, frail but probably will do for a TAVI. Got admitted, even more frail, heart failure admission. We said, no, we're not going to do it as an inpatient. Go home, we'll see you again in outpatient, see if you are just above the threshold or now below the threshold. So I saw her. She's walking to the bathroom. We're trying to catch a window in between all these hospital admissions. So I said, look, you're symptomatic. We'll try and do you. A day case. Why not? Because the home family is going to look after her better than any hospital can. If the TAVI's gone well, transfemoral, then why is there any reason to keep her in? So she came into the hospital on a wheelchair because it's a long distance and went out of the hospital in a wheelchair, but nonetheless got her TAVI. So I would summarize to say the main obstacle to day case TAVI is probably in your mind, and I want to change that mindset to say that what you should really be asking is, why is that next TAVI not a day case TAVI? What is stopping that person being a day case procedure? And those who are old enough in the room will remember that it would be very strange these days to do a coronary angioplasty and keep them overnight. But I'm old enough to remember when day case angioplasty came in and people thought that was insane. The patient was almost certainly going to die at home the following night because we'd sent them home. No, now day case angioplasty is de rigueur. I'd suggest so should TAVI be. Thank you.
Thanks very much, Iqbal. That's pretty inspiring stuff, and you've shown us how day case TAVI has become from a one-off, that 71-year-old very fit, healthy patient during COVID, to being the reality at Imperial. I'm interested to hear what is your. We're always interested to hear about screen failure. What is the most common reason that you wouldn't select someone for day case TAVI?
So that's an excellent question. So as I say, the default is, can we do a day case? And the most important reason is if their social support is just not good enough. And so that's the main limiter that we have. They don't have that adequate family network to be able to support them at home. And it's remarkable how many old people there are that have no family, no friends that could even spend 24 hours with them. The next group is where the ECG already shows right bundle, left axis. Even I'm not bold enough to stick a day case TAVI in those. So it's social support first, the ECG second, and pretty much nothing else.
And then when it comes to those who were selected to be on the day case pathway who then don't end up going home the same day, is that usually the ECG or?
So almost invariably it's the ECG. Very, very rarely does TAVI wobble unexpectedly, but it can do. But if the ECG unexpectedly broadens out, then of course we become nervous. So even with a balloon expanded valve, sometimes as you cross the valve, it goes into left bundle branch block. If that's resolved by the time it's 4 hours later, I'll send them home anyway. But if it hasn't resolved, then we'll keep them overnight just to be sure.
So we've got time. Gregory's asking, are your day cases bifemoral or single radial access? Now, we are going to get a talk on a bit more of the criteria, but what's your practice?
So we've now moved to pacing via a patch. Okay, so no venous line now either, but the majority of the cases I've shown you were bifemoral access and a venous line, but the anaesthetist in the room, they do nothing except for give intravenous paracetamol and have a chat with the patient. So the answer is we've now moved to a single femoral and a radial access and no venous line, but the majority of the 280 I've told you about have been done bifemorally with a venous line.
And sedation?
So sedation has moved at Imperial from general anesthetic and 200 people in the room to now, I like the anaesthetists, I want them in the room, and we have them available. But they're not doing anything now. They give enough sedation to keep the patient comfortable, but starting off with IV paracetamol, local anesthetic, and on a Monday they are not allowed to give any sedation unless I agree it as a TAVI operator. Because if they start doing something that I'm not aware of, you start losing control of the patient. If in fact they are calibrating the sedation to when I'm really making the patient uncomfortable, then that's a team decision and we're all aware of it. So the anaesthetist is my friend, but that friend has to cooperate and communicate with me.
And how about a very practical question? I'm sure I'm not alone in we get stuck at slightly strange points in the pathway. For us, the one that generates the most frustration is blood tests. What do you do about, well, firstly, do you group and screen these patients? And secondly, when do you do that?
So they have a pathway where they come the day before, and so they've had all their blood tests and their paperwork done in advance. They have a phone pre-assessment a few days before, but because the cross-match doesn't last that long, they come the day before for a blood test. We have a local hotel, and as well as hospital accommodation for those traveling a bit more distant. And so they're not taking up a hospital bed. It's a cheap hotel accommodation, but they visit the ward, have their blood test, have some obvious paperwork done. That final check to say, yes, you did stop your apixaban, and then they arrive first thing in the morning at 7 o'clock for their procedure. We tend to do them as either case 1 or case 2, so that by 5 o'clock in the afternoon, they're on their way home.
And I guess that illustrates that this whole concept is not something that you can do ad hoc on the fly. It's organised. The logistics are really important. And again, we'll come on to that later on when we talk about the critical nature of having your TAVI nurse specialists involved in this pathway.
Yeah, it's definitely a team effort, isn't it? I think we will move on to our next talk now. So we're going to hand over to another leading light in the UK for day case TAVI. Seth, over to you.
Hello, everyone. My name is Seth Vijayan. I'm an interventional cardiologist working at the James Cook University Hospital in Middlesbrough. So my task is to present the ideal patient pathway for day case TAVI. Those are my disclosures. A few months ago, a group of experts got together to discuss whether we can come up with a UK consensus protocol on the day case TAVI. And these are some of the eminent experts who gathered together to discuss this. And I'm going to base my talk mainly around that and also touch on our experience in Middlesbrough. So unlike Iqbal's experience, our first case happened in quite an ad hoc manner, really. It was pre-COVID. There were no bed pressures or anything. This was just a by-chance occurrence that a gentleman had undergone a absolutely smooth TAVI, and he happened to have an ICD in situ. By the time we were seeing him on the post-TAVI ward round, he had got himself dressed and wanted to go home, so he was allowed home. So that's where our story began. And then we formally introduced a day case TAVI protocol because we were already doing same-day admissions. It was day case from the outset. Initially, we only included patients with pre-existing pacemakers or ICDs. So in the months that followed, 13 patients were studied, and they all had pre-existing devices, and 12 out of 13 patients went home, and the one patient who didn't go home, she was a bit unsteady on her feet and was discharged home the next day. We published this data, and from 2020, we extended the program to patients with normal baseline conduction and also those coming for valve and valve TAVI. So how are we doing now? Over the last 3 years or so, we now routinely screen everyone for eligibility for day case TAVI. We've screened just over 600 patients, of which 45% were deemed to be eligible for day case TAVI. Of those who were eligible, about 41% go home the same day. That's about 18% of our all TAVI patients. There's no difference in 30-day mortality, readmission, or post-discharge pacemakers. When we looked at the predictors of success, having a pacemaker in situ is one, and use of balloon expandable valve is the other one. So how do we select patients for day case TAVI? This is what we came up with from the consensus. It's sensible to start with kind of straightforward cases and move up on the complexity to less straightforward cases. So I'll focus on this one. For centers starting day case TAVI, only include low complexity transfemoral TAVI with a calcium score less than 5,000. The cognitive function preferably should be normal and normal ECG or pacemaker in situ. They should be independently mobile with excellent social support and preferably living close to hospital, although Iqbal touched on some of the other arrangements that can be made for those who are living far away from the hospital. And as you gain more experience, you might want to include patients with more abnormal ECGs or cognitive impairment, higher calcium score, LV dysfunction and such. And to be honest, the group at the right-hand side, I would say, are exclusion criteria, which mainly includes higher degrees of AV block and right bundle branch block, or atrial fibrillation with slow ventricular response. So when do these patients get into the pathway? Patients are usually identified at various stages in the pathway. The concept of day case TAVI must be introduced early, and family support should be explored. So we do this often at the outpatient appointment with the doctor, and it gets reinforced at the pre-admission. We have a pre-admission clinic a week, maybe a couple of weeks before they're due to come in. The concept is reinforced. Their patients and also the family are educated on what to expect on the day of the procedure. Early mobilization protocol is discussed, and all of this helps to allay their anxiety. It's bad enough thinking about a valve replacement under local anesthesia. And travel plans are also explored at this point. And on the day of the procedure, those patients who are identified as potential day case candidates are scheduled early to allow more time for recovery and mobilization. We aim for a minimalist TAVI procedure that is under local anesthesia and with minimal sedation. Ultrasound-guided access is almost mandatory, and radial secondary access is preferable wherever possible. We do not put in central venous or urinary catheters. The procedure should be free of major complications, and good access site closure must be there to successfully go for day case TAVI. If temporary pacing wire is used, it must be removed in the cath lab. And we often we advocate post-TAVI echo and or hemodynamic assessment. Post-procedure, early mobilization protocol is enforced. ECG and echo are reviewed against the discharge criteria, which I'll come to. Sometimes the social circumstances may have changed, so that's double-checked. And if they're stable and mobile and back to their baseline, they're good to go in 6 hours. And they're also given information about who to contact if there's any issues. So this is an example of a mobilization protocol, what we practice in James Cook. So on arrival to the ward from the cath lab, they're often lying flat or they're at 30 degrees. The first hour, we observe them closely for access site and also vital signs. And then between about 1 to 3 hours, they're sat up gently. And after about 2 hours, they're sat out of bed. And after 3 hours, they are encouraged to have full mobilization. So discharge criteria, we look at the ECG for any changes. We review the echocardiogram for any AR, pericardial effusion, and other things. And we also look at neurology, whether there's any confusion, any signs of stroke or anything like that, and also look at their access mobility is back to baseline, have they eaten, have they passed urine, and whether their social support is still intact. Our follow-up, we usually follow them up the next day. Our nurse gives them a ring, and then after that, it's a standard post-TAVI follow-up, which is an echo and review at 4 to 6 weeks for us. So looking at why day case TAVI might fail, often social issues, as Iqbal said, is one of the main reasons. Planning and addressing them early can actually mitigate that. Delay in echo is a problem. Our way of overcoming that is we do echo in the lab. So often when we are closing the groin, there's a full template echo happening around the same time. Deconditioning, this can be a problem, especially in the very elderly. And the rapid mobilization protocol and also avoidance of sedation is actually quite helpful in this. Vascular issues, but this is quite rare these days, especially with ultrasound guidance. Conduction issues is a problem, and refinement of implant techniques and strict discharge criteria can avoid problems from it. I know that in some health systems, there's a problem with reimbursement if they don't stay in for longer than 24 hours, and I don't really have an answer for that. That's a difficult problem to overcome. So what's possible in the future? So in June 2023, we embarked on a little experiment. We selected 10 straightforward transfemoral cases, of which 2 had previous pacemakers, and of the 10, 7 went home the same day. So maybe that's the way forward. I would urge you to think. So in conclusion, I hope I've convinced you that day case TAVI is feasible and safe if facilitated by a strict protocol, careful patient selection, patient family and wider team education, and followed with a minimalist TAVI procedure and rapid mobilization protocol. Among those, I can usually only claim credit for the minimalist TAVI procedure. The rest, everything is usually supervised by our excellent TAVI specialist nurse team. Thank you.
Thanks very much, Seth. 10 TAVIs in a day is an achievement, but to get 7 of them home is even more of an achievement. I'd like to bring Gemma in now, if that's right. So Gemma, you're working in the same hospital. And I know that our TAVI program would grind to a halt without our superb TAVI nurses and our administrative team who keep the show on the road. Talk us through the nursing role in making same-day discharge happen.
So yeah, I think Seth identified it really well there. It's probably all the other things that happen outside of the cath lab, because in realistic terms, you know, the operator is there to make sure the procedure goes smoothly with no complications, that the patient is safely delivered from the catheter lab to the ward, and then really it's everything else that goes on around that. So today we're talking about day case that involves the same day admission. As a team of nurses, we are responsible for seeing the patient in advance, making sure that the patient can literally arrive on the morning and without delay go straight to the lab for their procedure. And that includes some of the things that Iqbal mentioned in terms of the blood work, and also making sure that the patient is prepared for that emotionally and physically. And then following the procedure as well, really facilitating that recovery pathway. The early mobilisation, making sure the wards are bought into that protocol, and having an understanding really of the patient's baseline. Not every patient looks typically well enough to go home, but that's probably because they looked like that before. We haven't done a lot to them in the hospital. So it's really having an understanding of their background and baseline as well.
And everyone looks better in their home clothes than in a hospital gown.
Yeah.
So something that Gemma touched on, Seth, I'm interested in your perspective on this, is when does the discussion start? Because expectation management is part of it, isn't it? You know, if the patient comes in with a suitcase expecting a long weekend, it's very difficult to turn that round. When do you start the discussion about day case TAVI?
So I often, every patient gets to see a consultant first before coming to the pre-assessment. So often the discussion starts there, and the topic is gently introduced. And often it's met with by a gasp saying, oh, I'm bad enough having a TAVI and a local anesthetic. Now you're going to send me home on the same day? I'd rather not. And then some people are obviously quite okay with that. And then the main allaying of anxiety happens when they come to pre-admission, when our SPNs actually go through what to expect on the day, what early mobilization means, that that we encourage mobilization in order to get them home and to get their functional ability back. And once they understand it, they're quite okay with that.
Got a question from the audience.
Hey, Andre Pop here from Chicago. Great presentations. We just reported 246 cases, same-day discharge, and we're probably now up to 260, 270. But I think, looking at Seth's data, which was amazing, your A, B, and C categories, I would be very reluctant to even dream of a patient in class C. And I think, as cardiologists, sometimes we look at what's the most difficult thing you can do. And I think the promise of same-day discharge is predicated on pristine results, right? So we have data at 1 day, at 3 days, at 7 days, showing that nothing happens to these patients. No pacemakers, no groin complications, whatever. And I think, Sandra really led the way on this with the 3M data, which was pristine, basically. And it is mind-boggling that this has been done for more than 10 years now, and we still have only 320 cases reported in the largest meta-analysis. And in reality, 20 of those were double counted because they were mine. So we have to publish this. And I can tell you that we're going to publish our data, but everybody needs to publish this if we want the field to move forward. Thank you.
May I respond to that? Because I'm collecting the UK data. We've got over 600 cases now across the UK. So we'll get that data together now, because I agree. People want to know that it's safe to do. And just to clarify, the C group was the group that even I would not do. So that was an exclusion criteria. Yeah. A and B. A was start, B was I'm doing it all the time, and C was no, even I wouldn't do it, just to clarify.
I think we have another question from the audience.
Oh yeah, thanks, Mohammed Al-Khalid, Freeman Hospital. Thanks for the presentation. We do have a well-established same-day discharge. We've probably been labeled as an outlier the way we do it compared to the current practice that you guys have published. I have two questions. The first one is, I haven't seen the proportion of balloon versus self-expanding valve, both in Seth and Iqbal's data, and whether the changes in the ECG matter, whether it's a balloon or self-expanding. The second point is the development of left bundle. I'm not sure whether it's a myth. We have published our data about the new onset of left bundle, and there are a sizable minority. They could still go home on the same day safely. And the last bit is the late pacemaker. There's always 5 to 10% risk of late pacemaker, which you guys haven't actually shown in any of the presentation. It does exist no matter what you do. And usually it happens 7 to 10 days after implant.
So they're all valid. And so I did show the people who'd had pacemaker or not. So if it's an Edwards valve, then over 85% don't have a pacemaker. Some do. Okay, and then for the others, for the Medtronic ones, it's 60-40 in our hands. I know that you've pioneered actually doing quite a lot of Medtronics without a pacemaker. The left bundle branch block data, not all.
Sorry, Iqbal, so do you actually, will that affect your decision about the platform you use if the patient has or doesn't have a pacemaker? I.e., if the patient has a pacemaker, you'll be more leaning towards self-expanding. If they don't have a pacemaker, you'll put a balloon expandable by default. Does that count?
So the answer is, again, a valid question. If they've already got a pacemaker, you can put whatever you like in. If they haven't got a pacemaker, then for a large chunk of our program, we were doing only balloon expanding. But now we are actually, because we're learning about the data ourselves, sometimes learning from you as well,
Published,
is that putting in a self-expanding valve as well, as long as the operator is putting it in an optimal way, it's as high as possible, and we're watching carefully the ECG. So this is not a balloon expanding session, but actually we all know that if we're starting out, the balloon expanding valve gives you a bit more of a safety margin than self-expanding. There's much more data, but I think that is beginning to change in any case.
And the left bundle after?
So the left bundle, I think if they persisted, now what I haven't seen is very good data to say that what happens to left bundle. If the left bundle is more than 160 milliseconds and it was bad, it was okay at the start, they're almost certainly going to end up with a pacemaker. They may revert, but they're not going to go home. If the left bundle is, partial left bundle and it's an Edwards valve, then I probably would let them go home. But I think that not all left bundle is the same. And if someone's already got left bundle, then actually I have done balloon expanded valve and sent them home. Because as we know from the anatomy of the AV node, the left bundle is what would get hit first by your valve expanding. So if that's already gone, that's less of an issue. If you already have right bundle and the left bundle is about to be hit by your valve, that's a much more dangerous situation. So I'm not doing any right bundle day case, but I have done some left bundle day cases.
Yeah, just because interesting on SET protocol, they say no change in the ECG. And if you have a right bundle with a balloon expandable and a remain right bundle, that will fit the criteria and the patient will be a candidate for same-day discharge, which everyone would be reluctant, including me. Having said that, I've sent 3 patients home on the same day with the right bundle. Now, just to go back to the left bundle, basically, we have characterized left bundle. We have published this data on left bundle, and there's a sizable minority of patients who develop new onset left bundle. They are safe to be sent home on the same day, and we have published this criteria already, and it is actually, I'm happy to share with the group.
So we're gonna move on. I'm so pleased that we're having such good discussion. So thanks for your contributions. We've got some more questions from the audience, which we'll come to next. But we're going to move from Middlesbrough to Vancouver and hear a little bit about the role of clinical valve coordinators. Sandra.
Oh, thank you to the organizers for including me. And I'm pleased to talk a little bit about those pieces of the puzzle that we're just talking about the fact that we want no surprises and no mistakes over the course of the concept of evolving day case TAVI. So I'm going to highlight a little bit the role of the clinical valve coordinator. Those who know me know this is a bit of a passion project of mine, of championing the role that nurses play, ensuring that success is not when the device goes in, but when the patient goes home. So it's an imperfect title for a perfect role. Multiple names to this. The concept of coordinator has not served us well, because it does not per se describe a clinical role, which fundamentally it is. We're not talking here about a secretary. We're talking about a full member of the heart team who has been labeled by various terms across various regions, increasingly evolving to this idea of clinical valve coordinator. If I could pop in the idea of a true clinician in there, I think it would be really helpful. Because this role has been, I think, established early on during the pivotal trials that happened in the early 2000s, recognizing that there was a degree of patient-facing responsibility in terms of case management, but also program and system-facing. And we tried to write this up in a number of manuscripts that have continue to serve as a basis to support role clarity and organizational integration of these essential roles. So what are the key pillars of the role? It's first of all this idea of clinical coordination of the patient journey. So we're not talking about scheduling the echo or the CT. What is the role here is ensuring patient is on a pathway from a journey of care that comes from disease recognition to post-procedure follow-up. There is a component of direct and indirect patient care that is operationalized, for example, in the ongoing measurement of function and frailty, ensuring that there's a degree of clinical triage in the role to make sure that the queuing of patients really reflects the clinical needs of the patients and the programs. And then lastly, of valve program leadership, meaning that this is a key contact for the implementation of clinical pathways, of things, important components such as mobilization protocols to ensure that all members of the team at every center is really functioning in a streamlined and standardized way. This role can be held by a number of clinicians, including registered nurses, nurse practitioners, or nurse specialists here, physician assistant in some jurisdiction, and allied health professionals. But foundational to this is an understanding of cardiovascular care and the patient and the program. So why does this role matter? And again, we have very limited evidence on this, but we know that it matters for patients from a patient navigation component, being a single point of contact, the importance of someone who knows the patient, who can not just educate the patient, but also lead the patient through shared decision making. For the team, it is around efficient coordination, communication and planning to make sure that all pieces of the puzzle are in place, and supporting the assessment and that clinical triage of the patient. And lastly, for hospitals, it's around supporting program growth. I think we found over the last 10, 15 years that if you have a program that does 50 to 100 patients, maybe it's okay that you can kind of teeter and hold on to the physician leading some of this work. But if you're looking at program growth, and we know that we are all looking at increased demands on our patients, that brings us to a tipping point for which there has to be somebody in charge who is the main point of referral. And I think here many people will know that patients are more likely to know the coordinator than the implanting physician by their name and being that point of contact. And again, I think that is a real metric of quality of care. And then lastly, around improving efficiencies and helping introduce contemporary evidence to enact change and ongoing quality improvement. And we had some data in the European Registry benchmark study where we were able to show that prior to the implementation of the benchmark best practices, which was a bundle of evidence-based recommendations to, again, streamline and improve outcomes, that in prior to benchmark, in centers that did not have clinical valve coordinators, the total length of stay was about 9 days. And I know that there are some European specificities around that. But then over the course of the implementation of the benchmark program, which required this role to be developed, supported, and implemented, able to achieve nearly 3 days decrease in length of stay. So to the administrators in the room, I think this gives us a signal of the potential of the role. Now, the latest guidelines have come out, not so much about the role, but some of the functions that are embedded in this role. And I think it bodes on us to move forward with these recommendations by standardizing role clarity. And this is what we're trying to do with the upcoming statement that is endorsed by both the APCI and ACNAP, which is the Nursing and Allied Profession Associations, where we have brought together a series of multidisciplinary specialists to look at role clarity, the competencies, the infrastructure and organizational integration of the role, and then some proposed evaluation framework to be able to measure the impact of this role. So this should be coming out hopefully soon. So in terms of then supporting efficiency and patient safety for day case TAVI, what does the role specifically bring? Well, it first brings that idea of clinical screening. We have a program in Vancouver that is now coming around 5 years old, collaborating with others such as Andre Pop to be able to put this in place. And the criteria that we use in our accelerated recovery TAVI program is our patients are local, social support has been mentioned before, no major mobilization issues, no language barriers, low frailty, and then a nursing agreement that this patient is suitable and the family is interested. The coordinator also plays an important role in patient and family teaching to support early discharge planning, and then importantly, to ensure we have an efficient clinical pathway where, again, there are no surprises and no mistakes. And so the role of the clinical valve coordinator is embedded in these quality metrics, and as well collaborating with the rest of the team to make sure that the puzzle of TAVI is well enacted. And then lastly, trying to close the gap here because we know certainly in Europe there is an uneven adoption of the role of the clinical valve coordinator. So we have recently completed an environmental scan in collaboration with many in this room to describe if and how the role of the clinical valve coordinator contributes to TAVI programs in Europe and how much it aligns with the position statement that we're about to put out. Again, some very preliminary findings. We were lucky to receive data from 275 participating centers across multiple regions. Interestingly, we found that 1/3 of the centers said that they did not have a clinical valve coordinator, but 2/3 said that they did. And looking more into the data here, when a clinical valve coordinator was present, interestingly, it was often assumed by a physician or by a secretary or a clerk. So I think it tells us this is a real signal that that is not true. It might be doing coordination, but it's not doing the coordinator role. So I think this was going to be interesting. And in many of the cases, the role is unfunded. When we looked again at some responsibility, this is a heat map of a Likert scale. So on the y-axis here, you've got the various competencies, and then at the bottom, the responsibility ranging from a primary responsibility to no responsibility at all. I just want to highlight a few things to tell us that the person might think they're doing clinical valve coordination, but actually it's not fully aligned with the competencies of the role. So looking at coordinating the assessment pathway, coordinating procedure planning, managing in-hospital referrals, which are really cornerstones of the role, you can see that those range, those colors ought to be darker if there were a full adoption of the competencies. And again, for the sake of time, I can't go over this much, but coordinating multidisciplinary heart team meetings, conducting clinical triage. This data is telling us that there's a lot of heterogeneity in some of the competencies and how they are enacted. So we've got some work to do, and I just wanted to highlight this last bar here, where attending the procedure in the cath lab, for example, people ask, does it need to be a cath lab nurse? Well, no, it does not. It needs to be a cardiovascular clinician who's got these competencies to be able to assume these responsibilities in terms of assessment, coordination, and program leadership. So when there was no clinical valve coordinator, what did we hear? Who's doing this work? Well, the physicians are doing this work. And overwhelmingly, either with or without a surgeon. I see people nodding in the room because that is you doing this work to be able to move your programs forward. And what were some of the barriers to implementation? Well, funding, lack of understanding of the value of the role, a lack of organizational support, and I think we know we are facing a huge health human resource crisis with a lack of staff. And so what is needed for many centers? There's a business case, a clear job description, which we're hoping our statement will bring, and then the availability possibly of new funding. But importantly, when we ask centers, okay, you do not have a clinical valve coordinator, what kind of priority is to this? And I think overwhelmingly people were kind of having a call to action for help in their centers. Lastly, just highlighting when we're thinking of evaluation, what are some of the signals that we saw here? And so what you see here in these columns, centers that said they had a valve coordinator with the caveats that I just mentioned versus no. And what we found is when there was a clinical valve coordinator, and this really harps back to the work that Gemma McCullough has done, more likely to have being able to admit patients the day of the procedure. Again, the administrators in the room here were saving a whole bed and a whole day and probably leading to less cancellations. But interestingly, in 13% of the cases, no clinical valve coordinator, it was even more than one day, so maybe 2 nights in hospital. Couple of metrics in post-procedure care here. Again, much more likely when you have a clinical valve coordinator that you're going to have a bed rest time that is under that margin of 4 hours, and we've got lots of evidence for that. But look at this number. Over 50% of patients staying in bed 12 to 24 hours and beyond, right? And I think that speaks to the absence of leadership and somebody who can champion the clinical pathway here, and this then results in differences in length of stay. So just in closing, I hope I've convinced you that the clinical valve coordinator is a central member of TAVI teams, and this is particularly important in the setting of day case TAVI, given the puzzle of those competencies that are required, and I hope we have collectively new opportunities to define and strengthen the role. Thank you very much.
Thanks very much, Sandra. I think I am going to guarantee to you all that we will finish on time because I know you've got places to go. So we'll go straight on to the next presentation and then we'll have some discussion time after that. So we've got some great questions coming in. Keep them coming. But over to you, Francesco.
Yeah, thank you, Sam. I'm ashamed because after this fantastic data and experiences that we heard, I have to give the bad news. What is the reality in Europe? I'm sorry about that, but this is how it is. So let's take a look at the data that we have. First of all, same-day discharge is not common in Europe, absolutely. Actually, if we look at this data, 2022, just focusing on this part of the slide, you can see that 24 hours discharge after TAVI was performed only in 12% of the centers. So we are far away from same-day discharge. Even if 25% of participants to this survey would consider this strategy. So we are open-minded, but we are not practicing in this way. So let's have a look at some countries. France, we have national-wide data. And you can see, I mean, this is common throughout all the countries. You see a huge variability in terms of length of stay of patients. But again, the mean or the median is beyond 5 days overall. So yeah, as early discharge is considered to be safe, potentially associated with better term outcomes. Early mobilizations, there are programs, there are data in France, but you see that this is what is the picture of throughout the country. Spain, nothing very different. For sure, there is an improvement that this paper demonstrated between an early cohort and the years 2009-2013 and a more recent cohort, still not very recent, but you can see the data around mean and median between 8 days, 6 and 8 days. So still far away from short length of hospital stay. Germany is a very peculiar country because in Germany, the current DRG system does not reward early discharge. Actually, you should keep the patient in hospital at least 3 days to have a full reimbursement. If you don't keep them in the hospital for 3 days at least, then your DRG will be reduced. So it's not economically convenient. So this is the situation. Italy, we don't have nationwide data about that. So I had to take the data from the benchmark study. And in benchmark, of course, I mean, applying the best practice measures, we were able to reduce consistently the length of stay, but still you can see that the average was 7 days. So for sure, not short. Same-day discharge, just some occasional report, like in this LinkedIn post by our friend Corrado Tamburino, but and there is a huge variation between centers. As a former president of the society, I can tell you that the situation is very, very variable throughout the country. This slide, you have seen this. To me, it's interesting just to highlight that maybe you see that Germany has the highest number of procedures, so maybe they don't need to have a fast turnover of patients in the bed. But despite this, that of course is not the only reason to go for same-day discharge. I think we should still go in the right direction. We should still go in the direction of a change of mindset, as pointed out by the previous presentation. So let's analyze what can be the main causes of late discharge in Europe. And I think there are 3 major categories. One is clinical, the second is logistics, and the third is cultural one. The clinical, of course, we've heard the most important one is the fear of conduction disorders, some comorbidity, and maybe bleeding and vascular complications that likely are very limited nowadays. Logistics, we have heard of the critical role of the clinical valve coordinator. Clinical valve coordinator is absolutely fundamental to have success in this early discharge program. Reimbursement. Of course, in some countries there are some issues, not only in Germany. For example, also in Italy, if the patient does not stay in hospital at least one night, there is a penalty in the DRG. And then there is something which is cultural, the perception of poor care from the physician and the patients and the family of the patients. And there are also some fear of legal issues. But, this is, I think, can be our conclusion. Clinical are sound. I mean, absolutely, this pertains to patient selection, and we've heard that we can make patient selection, we can differentiate criteria, but this is something that we must do as physicians, and it's absolutely reasonable. But I think on the other side, we absolutely have to tackle the logistics and the cultural hurdles that nowadays cannot be accepted based on the data that we heard and that we hope will be published more and more in order to help us convince the administrator and the healthcare people, organizers. This is just a provocative slide to say that most of the time we have the fear that some early discharge may be inappropriate. In fact, many patients can come back to the hospital soon because of clinical reasons. Well, this is just anecdotal, but it's an interesting report showing that in this experience, putting in place an enhanced transitional care basically founded on communication between the patient and the physician, the nurses, the clinical personnel immediately after discharge was able to reduce by 85% the readmission in hospital, so we can say that basically those were inappropriate readmission. So we should not highlight too much this factor and this fear of inappropriate care in this patient, that when the communication is good, they can be discharged home safely. This, again, the data from benchmark perspective in Europe, 28 centers, 7 countries, 2,400 patients. The results have been already shown. So with this program, we were able to reduce the length of stay overall, and especially, but take it at this, there are still many patients going to the ICU, CCU, and intermediate care. So it's something that we should work on it. This is, the reduction by putting some measures in place was consistent in different countries. You can see here, but still, again, the length of stay is a bit long. So there are efforts all over Europe to reduce the length of stay, but despite these improvements, day case TAVI is in most countries still far away from becoming the standard of care. So my conclusion is that early discharge, not only same-day discharge in Europe, remains not adopted uniformly. There is a lot of variability throughout the country and throughout the hospital, also within the country. The reasons include the lack of need, maybe in some countries, but again, this is not the reason not to go in the right direction. Regulation and reimbursement, we have to tackle this. Skepticism of patients and healthcare providers, we have to tackle this with data. Lack of infrastructure, and we need absolutely to have the CVC in place and to have in place early mobilization protocol, because all available data, and those that hopefully will come, support short hospital stay for selected patients as a safe strategy, cost saving, and also a potential way to address growing TAVI demand in many countries, in many hospitals. Thank you.
Thanks very much, Francesco. So shall we perhaps look at a couple of audience questions, Claire?
Yeah, so perhaps if I could come to Gemma and Sandra, a couple of questions really about the role of the CVC. So someone's saying, is there any consensus or any data on how many of these clinical coordinators you need for a TAVI centre, depending on the size of your programme? We've heard, obviously, from both of you how vital they are. What's your feelings in terms of that? I know there's some UK consensus, isn't there?
That's right. There is some UK consensus where, and it really essentially it's a loose consensus, but it suggests that you should have one TAVI coordinator per 100 cases. Now, as Sandra demonstrated very well, the role of the TAVI coordinator is very diverse. So simply attaching it to number of TAVI cases, I think in some situations could potentially cause some downfall, because we see all of that work in terms of the patient workup coordination leading up to the follow-up as well. And, that's some work that we've been doing, trying to really understand the European market. I don't know if you want to touch more on that, Sandra.
Related to the complexity.
1 for 100 in Canada is not going to happen, I can tell you that. Our coordinator probably manages 400 procedures, which probably means managing 500 referrals. And also, then there's the whole mitral and tricuspid space that is evolving, and increasingly we're finding that it's much better to build a comprehensive structural heart program. So I think those pieces are unknown. What we know is that it's somewhere possibly in that 300 range, with clerical support, so that we have clinicians doing clinical work, not secretarial work.
And
so, yeah.
Sandra, just to, somebody asked directly, when you transitioned to your same-day discharge and your day case TAVI, who was it you had to persuade? Was it, they've asked, was it the administrators? Was it the commissioners? What work do you have to do behind the scenes to develop a day case program?
So I think it is a full quality improvement project. So it needs planning, it needs stakeholders, it needs champions. In our case, it was around advocating for patient needs, having criteria-based selection. So that was a very physician-driven piece, but also nursing-driven, and then having an implementation plan. I'm a big believer in feeding data back to the team to make sure that everybody is on board, and that piece that everyone has talked about, and ensuring that patients are aligned with our goals, so that they understand that the best place to recover is at home if they have the appropriate support, and also ensuring that if we do make a mistake, we learn from that mistake and revise our protocols.
So we're coming to the end of our time, so we'll have perhaps one final question.
Yeah, I'm just curious because we're trying to refine our same-day discharge program. And do you, in your centers, when you do send them home, is that a plus or minus decision? You send them home, that's it? Or do you have some sort of prolonged home monitoring, like pocket ECG or whatever you call it?
So we're running a project looking at TAVI, so have some home monitoring. And we don't know the answer to that yet, because they're randomized to either receiving lots of monitoring and going home, or not receiving lots of monitoring and going home. So our 280 are actually without that monitoring. If we think we need monitoring, they're not going home. And yet still 60% go home the same day, and not over 90% go home by the next day. So the idea of home monitoring will expand the program further, but it'll be a cost. So unless we have the data that the cost is worth it, then we aren't implementing it yet.
So you're able to, you have pretty high numbers, so you have very low numbers of left bundle branch block, or you send them home with the bundle branch block?
No. So because we're using a lot of balloon expanded valves, or they've got a pacemaker, then the incidence of left bundle branch block is pretty low, probably less than 10%. Okay. If you've got proper left bundle, you're going to stay overnight. And it may have resolved by then, in which case you're going to go home. Okay. One point I would make is probably not directly related to that, is to change the mindset. An old patient of 85 lying in bed for 5 days has probably lost 20% of their muscle mass, and they're never going to get it back. So the mindset really has to change, that you're doing the patient a disservice by trapping them in bed for whatever reason that is not absolutely clinical. And me taking my old lady who came in a wheelchair and sending her home has done her a service, not a disservice, because she can get back to the mobility that she had before. So, if that's the way we finish the session, I think that's a good way to finish, because change the mindset, both of yourselves and the patient, because mobilizing immediately is the right answer, not a fudge answer because I'm saving money.
So my job is to summarize this session, but I can do no better than that. So I would like to thank our audience. We've got some world experts on same-day discharge on the panel, but also in the audience, and very grateful to you all for your contributions and for staying. Thanks very much.